on to Chapter 9, Skeletal Muscle Relaxants. There are two ways that skeletal muscles can be relaxed. We can either block conduction to the spinal cord, or we can inhibit contraction of the neuromuscular junction. So one is peripheral, which is the skeletal muscle relaxants inhibiting muscle contraction, and the other one is more central, which is inhibiting or blocking conduction to the spinal cord. Regardless of the site of action, drugs classified as skeletal muscle relaxants are clinically valuable because they selectively inhibit neuromuscular function. This inhibition results in relaxation of the muscles. So you might use this in a patient that has a back injury and they need a muscle relaxer to relieve the pain. You'll see a couple different instances where this is used the more we talk about it. So skeletal muscle relaxation is desirable in spastic diseases such as multiple sclerosis and cerebral palsy, conditions in which the spinal cord has been damaged such as trauma or paraplegia, and injuries in which pain accompanies overexertion of the muscles, which is what I just mentioned. Surgical and orthopedic procedures and intubation are often facilitated by the use of skeletal muscle relaxants, as well as paralytics. So we have to make that trachea stop fighting the tube that we're trying to put down the throat, so we need the muscles to relax. Neuromuscular blockers inhibit skeletal muscle contractions by interfering with nicotinic muscle receptors. There are two types of neuromuscular blockers, non-depolarizing and depolarizing. The non-depolarizing blockers combine with the nicotinic muscle receptors, but do not stimulate the receptors themselves. So these agents occupy the site on the receptor so that acetylcholine cannot combine with the receptor and depolarization cannot occur. The depolarizing blockers inhibit muscle contraction by a two-step process. So succinylcholine, which is a depolarizing agent, attaches to the receptor and induces depolarization. And then it alters the receptor so that it cannot respond to acetylcholine stimulation. So this phase is, that last phase there is the neuromuscular blockade. Okay. Non-depolarizing neuromuscular blockers are administered intravenously, and the depolarizing muscle blocker, succinylcholine, is metabolized so quickly that it is often administered by intravenous infusion to maintain skeletal muscle relaxation. So instead of just injecting it into a vein, we're infusing it over a period of time to keep a constant level. Neuromuscular blockers can produce cardiovascular changes even at their therapeutic doses. So they can cause increased heart rate as well as arrhythmia even at therapeutic doses. So we always monitor these patients that are on the neuromuscular blockers as well. Slide 7 covers peripherally acting relaxants. So on that slide, let me just make it a little bigger. On that slide, you'll see cisatracurium, pancuronium, rocuronium, vecuronium, and succinylcholine are our most common neuromuscular blocking agents, most often used in intubation and to keep a patient intubated so that they don't fight against the tube that's down their throat. Okay, so adverse and toxic effects. The major toxicity of neuromuscular blockers is respiratory muscle paralysis. Additional adverse effects include malignant hyperthermia, which is basically an overall warming of the body above a temperature that is acceptable to maintain homeostasis, and increased neuromuscular blockade with drugs that inhibit skeletal muscle function. So any drug basically that inhibits skeletal muscle function can increase the action of the neuromuscular blocker. Because the non-depolarizing and depolarizing neuromuscular blockers are prepared as a solution for administration parenterally, mixing some solutions can result in drug incompatibility, and you want to be careful with that. Direct-acting relaxants, so dantrolene. Dantrolene is really only used to treat malignant hyperthermia and certain other spastic conditions, but most often in the hospital, that's what we see it used for. It's a direct-acting peripheral skeletal muscle relaxant because it inhibits skeletal muscle fiber contraction. Again, it's directly on the muscle contraction. So it interferes with calcium ion release within the muscle fiber. Calcium ions are critical for muscle contraction because they interact with the contractile filaments. So if you inhibit calcium ions, you've inhibited that contraction. Muscle spasms associated with multiple sclerosis, cerebral palsy, and spinal cord injuries reduce a patient's ability to perform daily activities of living, getting dressed, putting on your shoes, and tying them. So this is where we might see this drug used. Moving on to slide 10. The adverse effects seen from dantrolene include dizziness, vomiting, fatigue, weakness, and liver toxicity. Drugs that increase the effect of dantrolene on skeletal muscle include alcohol, antiarrhythmics, antibiotics, general anesthetics, narcotic analgesics, tranquilizers, and sedatives. Just a short list of interactions for you there. Centrally acting relaxants. Again, these are going to block spinal cord transmission. Drugs that relax skeletal muscle by a central mechanism depress reflex impulse conduction within the spinal cord. This change in conduction reduces the number of impulses available to produce muscle contraction, less spasticity, less pain. So GABA or GABA, which is a long name that you don't need to know, just remember GABA is a neurotransmitter and gets gamma aminobutyrate. Again, GABA is perfect for our use. GABA is the neurotransmitter within the brain. GABA binds to its receptors, pores open to the lipid membrane, allowing passive movement of small ions. The movement across the membrane makes the membrane hyperpolarized, which then leads to a decrease in membrane excitability. So keep that in mind as we move on. Spastic contraction of skeletal muscle may occur in response to overexertion, trauma, or nervous tension. Reflexes within the spinal cord repeatedly stimulate the motor neurons so that the localized muscle fibers contract intermittently. This perpetuates a cycle of irritation or inflammation within those areas. So centrally acting muscle relaxants relieve that tension, relieve that spasticity, and they can be given orally or intravenously. Most common adverse effects include blurred vision, lethargy, and decreased mental alertness. Overdose will produce symptoms of extreme drowsiness, depression of vital functions, including respirations, heart rate, as well as coma. So on the last slide, slide 13 there, you have a list of skeletal muscle relaxants. And we're kind of, again, don't remember the dose, just become familiar with the names. The ones you're going to see most commonly used in practice include baclofen, carisoprodol soma, which is now a controlled substance. Cyclobenzaprine is extremely common, and tizanidine. You'll see diazepam used, however, it's a benzodiazepine, it is a controlled substance, it is habit forming, so they don't use it as much as they possibly could. So again, baclofen, cyclobenzaprine, tizanidine, really commonly used for skeletal muscle relaxants. That covers chapter 9. And 8 and 10, or 10 was in a separate video along with 8, so if you're looking for that, look for 8. Any questions, please feel free to contact me.